Greetings, everyone, and welcome to a new roundtable during the EAU Congress. Today, we are going to be talking about the best of the Congress on prostate cancer. For this, we have invited three experts to our table. The first one at my left side is Dr. Jochen Batz from France, Dr. Sigrid Carlsson from the United States, and Dr. Phil Cornford from England. So we will discuss what is the best presented at the EAU and what changes can you see during the 2023 in the guidelines. For this, I will invite Dr. Sigrid Carlsson. She will give us an overview on where we are in early detection on active surveillance in prostate cancer. So welcome, and the floor is yours.
Thank you. So let's start with a brief presentation of where we are today in 2023 with early detection and active surveillance for prostate cancer. These are my disclosures. Well, let's start like this. We don't want to throw out the baby with the bathwater because the PSA test is really the best test that we have. And when we abandoned the test a couple of years ago in the US, we now unfortunately see a definitive and sustained increase in prostate cancer metastases in the US consistent with these decreases in PSA screening. And even more concerning is that the death rate from prostate cancer that had declined is now stabilizing. So abandoning the PSA test is not the solution, but we need to use the PSA test in a more smart way. Because if we do that, we know from the EAU trial and the Göteborg trial that regular PSA screening can really reduce the risks of prostate cancer metastases and mortality. So the PSA test really comes with benefits, but also some harms. So the question is, how can we use the PSA test in a better way to balance the benefits and the risks? And one way is the age to start. And so what we showed in the Göteborg trial is that if you start PSA testing before age 55, that can halve the risk of prostate cancer death compared to starting at age 60. So starting sooner reduces mortality more than starting later. We also now have a new market. So we used to only have the PSA test, but now there's risk calculators, we have genetics, and we have all these other reflex biomarkers that are available that we can use before prostate biopsy. And of course, the new kid on the block is the MRI that has been a major game changer in recent years. In the Göteborg 2 trial, men were then randomized to PSA screening and then followed by MRI and targeted versus targeted and systematic biopsy. And what you can see here is that among men who had an elevated PSA and then only performing targeted biopsy to the suspicious lesions on MRI, that could halve the rate of overdiagnosis, so the detection of insignificant prostate cancer, while still maintaining the detection of high-grade disease. So this is one way of mitigating some of the harms of PSA testing. And similarly, the Stockholm trial has shown that you can combine clinical information, PSA isoforms, and then genetics, and then follow it by MRI. And similarly, you can see then that if you perform targeted and systematic biopsy among men who had a positive MRI, you can save biopsies, you can decrease overdetection, and you can still maintain the number of high-grade cancers found. And it's important to remember that a chain is only as strong as its weakest link. So for this concept to be successful, you really need to have a high quality MRI, you need to have optimal reading of scans and a robust training program for radiologists and access to high quality targeted biopsy for this concept of pre-biopsy MRI to work in practice. What about genetics? There's been a lot of talk about genetics and do they improve our risk stratification in screening? Well, the problem is that many of these single nucleotide polymorphisms or risk scores actually don't discriminate men with aggressive from those with indolent disease. So they can find any prostate cancer, but perhaps not so specific at finding the high-grade disease. So they can add some, but perhaps not as much as we want to. So that's really the heart of the discussion here, that we want a test that can discriminate between the benign and the malignant prostate cancers, and especially finding the high-grade cancers. What's also interesting, and that's been talked a lot about here at this EAU meeting in Milan, is this new idea of organized quality controlled population-based program in the EU. And Professor Van Poppel and Professor Rabol has really been driving this and working with the EU and now starting these efforts of pilot testing different programs in the EU member states. We also have a lot of ongoing trials that have been mentioned here at this meeting and the plenary this morning. We had the PIs from these trials presenting updated results. And so a lot is being done in this space of risk stratified screening. So the PRO-based trial starting screening at age 45, the PRO-screen in Finland, which combines then PSA with 4K score and MRI, the Göteborg trial that we heard about that combines also PSA and MRI. And then there's two trials, Reimagine and MVP, that looks at screening just using MRI and omitting the PSA test. And what about active surveillance? We heard from Dr. Kuperberg earlier this morning that active surveillance is on the rise. So it's increasing its use among men with low risk prostate cancer. And it's now really widely adopted all around the world. It's the preferred care option for low risk localized prostate cancer in all of the guidelines. And it's also an option in select men with grade group 2. And if you look at the outcomes, this is just an example from our experience at Memorial Sloan Kettering, you can see that these men really have good long-term outcomes. And so it's a safe management strategy for appropriately selected and appropriately monitored men. And in summary, where are we with active surveillance? A lot of changes. Of course, it's not no treatment, but it's a strategy to treat when we need treatment. And shared decision-making, of course, is key. It's also important to increase the number of men who stay on active surveillance. And we see the long-term data show very low rates of metastatic disease and death. And we also now have increased the use of active surveillance in select men with grade group 2. MRI definitely has its place in active surveillance. It's here to stay, especially at the start of active surveillance, but it cannot replace the surveillance biopsies. And then we're looking at precision active surveillance using biomarkers and genetics, and then this whole concept of de-escalation or active surveillance light. So this is where we are today in 2023 with screening and active surveillance.
Thank you very much, Dr. Carlsson. I have so many things to ask, but let's wait to the end of the 3 lectures so we can have an open discussion between the 3 experts. So I would like to invite Dr. Walz. He will talk about the EAU highlights in prostate cancer. Thank you.
Thank you very much, Juan, for giving me the opportunity here to talk about the highlights in prostate cancer. This is the summary of the prostate cancer track inside of the scientific Congress office. So we selected these 3 abstracts together that I'm going to present here one by one in the following presentation. These are my conflicts of interest associated to this presentation. The very first abstract is looking at subgroup analysis of the ARASENS trial. You're aware of the ARASENS trial, looking at the effect of darolutamide together with docetaxel and ADT versus docetaxel and ADT alone. And in this study presented by Bertrand Trombal, they looked at the subgroups in order to help with the decision-making which patient group would be the most appropriate patient group for such a treatment. The method is an inclusion of patients with metastatic hormone-sensitive prostate cancer. They were randomized 1-to-1 between darolutamide plus ADT plus docetaxel versus placebo plus ADT plus docetaxel. And the subgroups they analyzed were the charted subgroups and the latitude criteria. The endpoint was overall survival. This is the different subgroups, and you see here throughout the different subgroups, you see an effect favoring overall survival in those patients undergoing a treatment with darolutamide plus docetaxel and ADT with a risk reduction of roughly 30% in the different subgroups. Where are we today now with the different subgroups you might encounter when having more hormone-sensitive metastatic prostate cancer? You actually see here the results from PEACE-1 looking at low volume and high volume. You see that in PEACE-1 actually you do not have a significant difference between the 2 arms by adding this intensified triplet treatment, by adding abiraterone to standard of care. The same is for GTIC-15 and charted. On the lower level, you have the low volume patients. On the left-hand side, de novo. On the right-hand side, the recurrent patients. And you see also the curves are not separating, not showing here a substantial benefit for the low volume patients. So these are the patients where we actually do not have a clear idea how we should best take them into a management, into a treatment once they are diagnosed. And in ARASENS, they also had the recurrent patients and the low volume patients as subgroups. And if you look here once more, the confidence intervals actually past the boundary of 1, showing that there's not a strong significant trend favoring a treatment with a triplet in this situation. So once more, also in this analysis, we do not have a clear idea how we should best manage these recurrent patients and the low volume patients. The question is this just an absence of effect in these patients, or do we just have a low number of patients that are included in these trials with these characteristics? We know that these represent usually between 20 to 25% of the patients included, so it might just be a lack of statistical power, or maybe they just have a good prognosis at baseline, so there is no need in going for any intensified treatment. We know that if you have a treatment with ADT alone, you might have 8 years of overall survival in these patients. So we do not have like a clear answer to this question, and a doublet might be sufficient in these patients, and you would not probably need to add docetaxel systematically here. The second data is looking at the STAMPEDE trial once more. You're familiar with this study design. It is a multi-arm randomized trial having a standard of care and then randomizing different study arms to this or against the standard of care. And in this study that is presented by Jones, they looked at the effect of biphosphonate zoledronic acid on the skeletal health outcomes in the STAMPEDE arms A, B, C, and E. So these arms were randomized between ADT versus ADT plus zoledronic acid, or ADC plus docetaxel versus ADT plus docetaxel and zoledronic acid. And the data from the skeletal-related events was coming from what they called routinely collected healthcare data from the hospital episode statistics. So it was not collected inside of the STAMPEDE data, but was retrospectively collected then from other data sources. And they looked at the effect of zoledronic acid, and the outcome was clinical fracture events. You see here the outcome, and the red line is of those patients who did not undergo a treatment with zoledronic acid. The blue line is these patients who did undergo a treatment with zoledronic acid, and you see here a significant substantial difference in the amount of events associated to fractures in these patients. And it is of note that this was happening in M1 patients. However, there was no difference in M0 patients. We know that in patients undergoing ADT with this standard of care at the baseline treatment does have a detrimental effect on bone health. Systematic prophylactic measures are strongly recommended here, and the current guidelines do recommend the use of bone-targeting agents only in the castrate-resistant situation. And this is based on Fred Saad's trial, published quite some years ago, showing here a reduction of skeletal-related events in the arm undergoing zoledronic acid treatment. And for the time being, this is recommended in the CRPC. Of note that this does not improve the overall survival in these patients. For the hormone-sensitive stage, actually, these treatments are not recommended because the trial that is shown here, they actually randomized placebo versus zoledronic acid in the hormone-sensitive stage, and there was no improvement in the survival without skeletal-related events in the study, where roughly 600 patients were included. So where can we put now this STAMPEDE trial? The big question is, how reliable is the HES statistics here? Can we really rely on what was reported here? Of note that the SREs were not a pre-specified endpoint in the STAMPEDE trial, and not sure that we can consider this being then practice changing. On the other hand, STAMPEDE is an excellent study design. High number of patients, more than twice the number of patients than in the study of Matthew Smith. And the STAMPEDE data was already providing us with practice changing information and data. So likely that this once more might be a practice changing approach. We need to wait for the final published analysis here to draw further conclusions. And then third, I think one of the most burning questions we currently have is the effect of metastasis-directed therapy in our patients, especially metastatic patients. And the ARTO trial looked at the effect of stereotactic body radiotherapy to the metastases in the castrate-resistant situation. We have some data out there looking at the hormone-sensitive stage, the STOM trial and the Aureoli trial, and this is one of the first studies looking now at the effect in castrate-resistant prostate cancer patients. It's an Italian study looking at the effect of stereotactic body radiotherapy together with abiraterone versus abiraterone alone in a randomized fashion. And there were oligometastatic castrate-resistant prostate cancer patients with less than 3 non-visceral metastases randomized between abiraterone versus abiraterone plus SBRT. And the endpoints were a biochemical response, more than 50%. That's the primary endpoint, not reported here. And the secondary endpoints were PSA drop and the complete response, defined as a PSA below 0.2. And roughly 140 patients were included here for this analysis. And this shows the complete biochemical response, favoring clearly the approach with SBRT plus abiraterone with an odds ratio of 2.4. The other outcomes, the PSA response was also favoring abiraterone plus SBRT, and there was no additional toxicity generated with SBRT. I think we need to commend here the authors to have done such a trial. Probably everybody who deals with metastatic prostate cancer is asking the question, should we irradiate the metastases or not? So it's very laudable to have this trial done. There are, of course, limitations. The sample size calculation is actually not very clear. We don't know what actually the suspected delta was between the two groups, which would substantially influence the sample size calculation and with the statistical power. And then the endpoint might not have been the most relevant one. PSA response, especially in the CRPC setting, is not the most informative endpoint. We might want to have outcome from treatment-free survival, as it was suggested by the STOMP trial, or progression-free survival, ideally. And then the last point is that CRPC is a very heterogeneous clinical scenario. So the selection criteria are a little bit unclear. What was the previous treatment the patient received before they progressed to CRPC, and then it's unclear what was the staging of this patient, whether it conventional imaging, whether it PET imaging, choline PET, or PSMA, and all these factors would substantially change the characteristic of this patient and the clinical outcome in the long term. Thank you very much.
Thank you very much, Jochen. And then we are going to, for the third and but not least lecture, we're going to see which are the biggest change in the guidelines that we have, thanks to all the data and all the outcomes that we have collected during 2022. This lecture will be by Dr. Cornford. So Dr. Cornford, floor is yours.
Thank you very much. It's really interesting. I've not seen the slides of my other two presenters, and it's interesting how many things that they mentioned are actually altering the guidelines already. So here we are. Here is the first new recommendation. You'll recognize most of the stuff at the top. We suggest that in asymptomatic men with a PSA level between 3 and 10 and a normal DRI, you should repeat the PSA test before further investigations, and that doesn't surprise anybody. We point out the importance of using a risk calculator or an MRI before doing biopsy. But the additional thing is the addition of additional serum or urine biomarkers, which have appeared on the guideline for the first time. Because now we've seen the data, particularly from the Stockholm 3 data, but other things are beginning to make a real difference to how we select our patients. And that is beginning to feed in. And as we get more data and we get more confidence, I'm sure that that strength rating will move from weak to strong. But we're beginning to recognize that this is a way of cutting down the number of people that need biopsies. So that's the first time this has come into the guidance. I thought it was just because MRI is so important. I thought this table is new in the guidance, and it might be helpful for people who are thinking about what they're going to do in the office on Monday morning. And what it is a combination of PIRADS and PSA density risk groups. And you can see that not only is what you can see in terms of PIRAD that is important, but also you need to think about the PSA density, and it will give you a risk of whether you need to consider biopsy or not. The risk in the little white squares is low, below the population risk. For the next square up is at acceptable risk, and you can see really for PIRADS 1 and 2 lesions, unless you've got a very high PSA density, you don't need to consider biopsies. And then with the intermediates, it is the PSA density that tells you whether or not you should talk about biopsy and how strongly you should consider it. In reality, all PIRADS 4 and 5 patients should have a biopsy. One of the things that is equally important is this guidance on prostate biopsies. We've moved away from transrectal biopsies and towards transperineal biopsies. And for all patients who are capable of having a transperineal biopsy, that is the thing of choice. This was written in conjunction with the infection panel, and it's an example of how the guidelines are trying to work collaboratively on the big topics. So you can see there were a number of meta-analyses done. Interestingly, the meta-analysis on the use of antibiotics with transperineal biopsy suggested that you don't need to use it. Personally, I'm still a bit anxious, if I'm honest, and on that basis, antibiotic prophylaxis is still there, but you can see the data on the other side of the slide says that in truth there is no evidence for it. In transrectal biopsies, if for some reason transperineal biopsy isn't available, and we know that these guidelines are used in 76 different countries around the world, it's not always possible, then the thing that you really need to think about is iodine rectal preparation before you do biopsies and using targeted prophylaxis. Fluoroquinolones are not actually licensed increasingly because of issues with tendinitis, and that becomes a problem. We've already talked about active surveillance, but one of the big changes this year is not only is active surveillance for low-risk disease the preferred option in the current guidance, it's the only option. Our argument is that everybody with low-risk disease should have active surveillance as their primary treatment. And we've seen from Matt Kopperberg's data that that's probably only up to about 50% in the States. And if you looked at his data that was presented this morning, there's an enormous variation between different centers. And we, like the EAU and now the EU, are increasingly keen to see us have a screening program that would allow us to detect people with high-risk disease. But the only way that you can justify that is by not over-treating people with low-risk disease. And this is absolutely essential. Interestingly, this still says 10 years of life expectancy. But having seen ProTech this morning and seeing that, in fact, at 15 years, it doesn't make any difference, probably you need 15 years of life expectancy before you should be considered for radical treatment. And I think that that may well turn up in next year's guidance. These are recommendations about exactly how you would perform active surveillance. We agree with Sigrid earlier that we don't think that you can get away with MR scanning and not doing a biopsy unless you have PIRAD 1 and 2 findings on an MR to begin with, a low PSA density, and at that point you probably wouldn't do a surveillance biopsy, repeat biopsy, in order to be eligible for active surveillance. So I think that's really quite important. And the other thing to say is we've said very clearly that if you've got low-risk disease, you shouldn't have treatment. It is also very clear that if you've got a change on an MR scan, the appropriate way forward is to biopsy it and make a diagnosis and understand what disease is there, not treat it on the basis of the MR scan change. Now for something slightly different. This is the management of locally advanced disease. This has changed significantly. For radical prostatectomy, if you are going to use this as part of locally advanced disease, the advice here is that this is as part of multimodality therapy. You might do it for people with clinically node 0 disease. And again, remember, this is on conventional imaging and not on PSMA PET. And we might come to that at another point. And that really the data for people who have got clinically node positive disease is that they would be better with radiotherapy and 2 years of abiraterone plus long-term ADT. And that is now a strong recommendation. And lastly, based upon the data that, again, that we've already seen from the PEACE study and from Arasens, we have removed the combination of docetaxel and ADT for patients who are presenting with hormone-sensitive prostate cancer, and instead replaced it with offer docetaxel only in combination with ADT plus either abiraterone or darolutamide if they're fit for docetaxel. And you've seen this study, which is PEACE 1, and this study, which is the Arasens study, because they both clearly show that the combination of a ARTA plus docetaxel is better than docetaxel alone. And so that is no longer a standard of care, which is interesting for someone who remembers docetaxel coming in and the enormous fanfare there was when docetaxel was first licensed for people with metastatic hormone sensitive. Now that is no longer standard of care. Lastly, I would just like to emphasize these. These are new in this year's guidance, and there are a number of flow diagrams. I can't take credit for it. Roderick did a lot of this, but these are new flow diagrams we hope might make it easier to understand how you would manage patients. This is the metastatic hormone sensitive prostate cancer. So I've got 2 takeaway messages. Please avoid overtreatment of low-risk disease, and please use intensified treatment for locally advanced and metastatic hormone-sensitive prostate cancer. Thank you.
Thank you very much for this nice and quick overview on the big changes on the guidelines in 2023. Now we're going to begin the discussion, and I think that for the discussion we can split it into first early detection, then we can talk about active surveillance, and then of course locally advanced and metastatic disease. So regarding early detection, we have been using digital rectal examination, PSA, for a long while. Then MRI came a few years ago. If we set a time frame, it came in the last second and has changed a lot in the diagnosis pathway of prostate cancer. But what happens with biomarkers? Why, until the date, we have, if you search in Google or whatever, you have a bunch of biomarkers in the market. Why are they not widely accepted? What is the problem with them? And how to introduce them in an early detection strategy? Sigrid?
Yeah, it's an excellent question. I would say, the bar is already pretty high with PSA. It's a fantastic marker. It's the best tumor marker we have. Its specificity for finding lethal disease 25 years later is super strong. The accuracy is 0.90. So just the total PSA is a fantastic biomarker in and of itself. So, it's a cheap, available test and it's everywhere. So I think, it's hard to you start with that test and where do you go from there? So, and then the Frida Total came, and then that helped us because then we could distinguish between, BPH and cancer. So that's also another test that's very, easy to use and that urologists have been using for a long time. And so then you have these other biomarkers, other tests in blood and urine that are available, and they are used. So it depends really on where you are. In the US, for example, they're used quite a bit. And then, of course, the new kid on the block came with MRI. And so all of a sudden you have a sort of a competitor on the market, and how do you integrate them and how do you combine them? Sometimes patients come with a biomarker first and then they do an MRI, or vice versa. So you kind of have more information. And so the more you have, the better, I would say. And then how do you combine them? And so Stockholm 3 is a multiplex test where you integrate, the clinical information, the biomarkers, and the genetics. And the 4K score is also one of those tests where you integrate the clinical information and the PSA isoforms. So I think we still need to do more research on how to, flesh out those pathways and which pathways is the best one. I mean, there are many ways to roam, but ultimately you want to find the high-grade cancers and not overdiagnose the Gleason 6s or the grade group 1. So I think the field is still struggling on which pathway is the best. I don't know if you would agree or have any.
I mean, Philip will probably comment on this. If you look at the evidence that is available between imaging, MRI that was quickly implemented the last second, as you say, and what we have available for the biomarkers, it's day and night. We have prospective randomized data providing level 1 evidence that with MRI you improve the outcome. You have very few biomarkers where you have the same level of evidence. We have the PROMISE trial, which in my opinion is the most important trial we had for MRI, where you did a template biopsy after an MRI, checking how many cancers actually are there, how many cancers you might have missed, and how many true negatives you have. And this provides you information of how effective a test might be to find a disease or rule out a disease. And we don't have this test for a biomarker. And as long as we don't have this test, I think we are unable to judge the real performance of such a biomarker. Unless you combine then a biomarker with the standard of care, which is MRI, and this was done for Stockholm 3. And I'm really happy to see that Stockholm 3 is integrated because it is the only biomarker we currently have evaluated with a strong reference test, which is MRI and the MRI pathway. And I think that's the reason why MRI was integrated very quickly, and biomarkers need to go this way. They did it finally, but there are not many biomarkers that are able to provide that evidence.
In the EAU23 trial, there are side studies where biomarkers are being studied also, and that's a randomized trial. And the same with the ProScreen trial in Finland, which is ongoing, large prospective randomized trial combining PSA, 4K, and MRI. So that's one such high-level evidence that we'll see. So maybe EAU Paris will have more data made on this.
I mean, I think that's absolutely true. I also think there's a slight transatlantic difference. So in Europe, the answer has been that MRI has been available and cheaper, and it's been very expensive in the States, and the States have gone a bit more biomarkery, and Europe has really bought into the MR story. And although I am a great proponent of the MR, I think we do need to be very careful, as you said, about quality. And one of the really important things is MR is brilliant if you set it up properly, if you get the right images, if you have experienced people who can do it. And biomarkers have not been able to touch that. They might have been able to add to it, and that is the beauty of the Stockholm 3 data. But you need to be very careful about making sure that the quality is good. And when you're introducing it, you need to look at the number of PIRAD3s that get called, and then what the biopsy tells you. And then if you feed that back to your radiologist, you will improve locally. And that is actually really very important.
And then it's also very important for this regard. The ultimate goal probably is to avoid the biopsy at all,
Yes.
Not having the risk of finding those low-risk, low-volume cancers. And for this, you would have to look at the negative predictive value. And that is a very individual, not a local number you will generate or have. So you would check locally what the performance together with your radiologist is. And if that negative predictive value is good, then you might use it to rule out the need of biopsy. And if it's not, then you might need a backup with systematic biopsies or follow-up, whatever. Mm-hmm. So as you said, quality is important, and the evaluation of the quality is very important.
And just because it was really good in the study doesn't mean to say it's really good in your hospital. And so it's really important that you know what your results are. Okay. I can't overemphasize how important that is for people watching this.
I think that's such a great point you make about avoiding biopsy, because we think about screening and early detection. We want to find cancer, but we also want to omit biopsy. We want to exclude people from being exposed to harm. So if you think about, it's almost like a funnel where you start with a PSA test, you continue with some risk stratifier, risk calculator, biomarker, MRI, and then biopsy. So you kind of have fewer and fewer men going on to biopsy. And if you start with a PSA test, it's a fantastic marker to also rule out, right? So if you have a PSA that's less than 1 at age 60, your 25-year risk of developing lethal prostate cancer is 0.2% from the Malmö studies. So that means that 50% of the population have a low risk, and they don't need to go on to biomarkers and MRI and all of that. So we need to think about who does not need a biopsy, who does not need treatment. We need to think about screening and active surveillance together in this whole chain, and not be so focused on finding the high-grade cancers.
Can I just raise one other question? I'd be interested in your views. So what do you think the value of digital rectal examination is in these people undergoing screening and MR?
It's a big debate.
How much does it cost?
Very free. But men don't like it very
They
much, do
don't
they?
like
And
it.
it puts them off coming for screening.
And the pro-based trial showed
Yes.
that they're young men, 45, they don't want a DRE, and
Yeah.
the utility is very low. I mean, the prevalence of cancer among those were very,
Yes.
very low. So, but I think we should definitely do DRE among those with an elevated PSA. You always
Different
do it,
question. Yeah, yeah.
you do it before the
Yeah.
trials and the biopsy. So, and the PLCO trial has shown the value of DRE in the slightly elevated PSA, so between 2 and 3 and 4 and above. But in the low PSA ranges, the utility of adding DRE to PSA is very low.
I agree, probably will not change anything in a true screening approach.
Yes.
Yeah.
But it's like with MRI, you have like the possibility not only to diagnose the disease, but to deal with the disease, what happens afterwards once it's diagnosed. And I think the DRE is still very important to understand what kind of cancer you're dealing with. And if you do it upfront at the very beginning, first contact, you have it done. So you have it inside of your data set and you know what actually happened or what the situation is with the patient. If you do it not at the beginning and you need to do it afterwards because you're in a certain situation where it might be of need, you might get not to a moment where you do it and then you're losing this information. So I do it systematic in all our patients because it's for free.
It is for free.
Coming back to cheap biomarkers, I'm very happy to see prostate density now applied in the guidelines. And this is very helpful because you are getting what you had, but you are squeezing it and you are learning how to use the tools that you already have. What made you, in the guidelines, apply PSA density into levels in order to avoid or go straight forward for a biopsy? What has been the change in the evidence there?
So there's a really big systematic review that was the underlying basis of that table that I showed you. And it began to look at the different risks. Because, of course, the thing with density is there's no obvious cutoff. So you can use different cutoffs depending upon which risk. And if you looked at the table that's in the guidelines book, you'll realize that depending how concerned you are about missing something, then you will work out which density you want to use. It's fair to say that I largely have used the 0.15 density, but there are people who are using 0.20 as a density. And if you're very anxious, then 0.10 is a gain density, but it's trying to split that out and collecting information that allows us to look at the risk. And you'll see in that table, it actually explains what the risk is for each of those combinations of PIRADS 4 and 5 and a PSA density of 0.2, the risk of having clinically significant prostate cancer, admittedly in that one defined as Gleason 3+4 or higher, was nearly 60%. Whereas if you looked at people who had a PIRADS 1 or 2 lesion, even if your PSA density was up, your risk was still only about 10%.
Coming back to something that is cheap, you say that's a combination between MRI and
Yes.
the PSA density. Can you say, okay, we don't need the MRI, we just work with the PSA density as we used to do a few years ago?
So this was largely PSA density calculated from the MRI. And I think that is perhaps, if you are very good at doing truss, then you can calculate PSA volumes well. If you use your digital rectal examination to calculate PSA volumes, that doesn't work. And MRI is so ubiquitous now, certainly in the UK, that the answer is everyone's having an MRI, often an MRI before they see me. So they'll have been sent with their elevated PSA, they'll have had their MRI, and they will turn up with that result by the time they see me. And they will already have a density calculation because they calculate the volume. It is for free because they've had the MRI anyway.
PSA density is around like for quite some time now.
Yeah.
And it obviously used in isolation was not a groundbreaker,
Yeah.
but by combining it with MRI, it seems to help really to stratify the patients we would like to keep out and
Yes.
to keep in.
And
So the combination
it tells
I think,
us
makes
some of those PIRADS 3 people don't need anything doing about it. And again, it comes back to trying not to find people with insignificant cancer
That's it.
and to try only to biopsy people who have a real risk of finding something that might actually affect their life going forward.
Thank you. We can wrap up and summarize in the early strategy discussion that we had. It's like we say in Spain. Now, in Spain, we say things are not coffee with milk for everyone. Now, in an early strategy, it's not coffee with milk for everyone. It's not PSA digital rectal examination for everyone. We should do a risk-adapted strategy, and we should learn how to use the tools that you have. Of course, in the ideal world, we might have biomarkers, MRI, everything. But with nomograms, with PSA density, which are cheap, we can also get good results in an early detection strategy. Okay, we can move to the active surveillance. We have two groups. We have low risk and intermediate risk. For low risk, thanks that now active surveillance is the only choice for them. And I heard in the plenary session in the morning a very sexy, let's say, or very sexy comment on Gleason score 6 or ISUP1 is not cancer. I think it's risky to say it. I would like to hear your comments on it. Is it cancer? Is it not cancer? And if it's not cancer, why do we do surveillance on it?
So I think that's why it is cancer. So pathologically, it's still cancer. I presented some of that stuff earlier in the week. I personally still believe that it needs to be cancer because if it's not cancer, you won't come for your follow-up. And therefore, you won't have active surveillance. You will have some form of loose monitoring or maybe no monitoring, because why would I come and have regular PSA tests and regular scans and repeat biopsies if I don't have a cancer? So I understand that the chance of this being a cancer that will kill you is really low, which is why you should be on active surveillance. But to say it's not a cancer to try and make people feel better about it isn't being entirely honest with them. And what those patients need is better support to come to terms with where they are and to engage in the process. And we work with a clinical psychologist for patients who really struggle because that's what they need, rather than they don't need to be told that it's not a cancer and you can go away, and they don't need an operation to drive their PSA down because it was never going to cause them trouble.
Yeah, it's a controversial topic. And Dr. Matt Cooperberg, he assembled the world's expert in a room about 2 weeks ago to discuss this exact thing. 3 hours, I think. I don't think we reached a consensus amongst the experts on, whether or not to call it cancer. So I think, we're all, it's mixed. And I guess the pathologist would say that it still, has the hallmarks of being, cancer with a, by definition. But then, others would argue and say that there might be less overtreatment and patients, might feel better. And so I think we need to study those consequences. And, I think we need more research in that space and whether or not we should change the nomenclature and what the consequences would be of that.
Good. Now moving to the intermediate risk patients. Now there's a subgroup of patients that of course will benefit from active surveillance that is not a no treatment strategy, it's just a delayed treatment if has a progression. What are your feelings about who are the best candidates for this? And if MRI, for example, a patient with a Gleason score 7, 3+4, of course, with a positive MRI has different outcomes for a patient that has a negative MRI. So MRI is really helpful in this, and we should rely only on MRI, or we should rely in other clinical and pathological factors here.
In our experience at Memorial, we've included some patients with 3+4 on active surveillance, and it's a smaller group of men, very selected. And again, we look at all the information. We have age, stage, PSA, grade, and also quantification of pattern 4, how much percentage of pattern 4, and also the millimeters of pattern 4. That's a very strong marker. So, maybe a few, like less than 3 millimeters of pattern 4. And so you take all of this into account, and also the patient's preference, if they prefer active surveillance versus active treatment. So you have, conversation, but it's important to really monitor that patient group more closely. It's more active surveillance than the Gleason 6s, but it is definitely an option for a very select group of 3+4. And I think in this space also some of the biomarkers might come in, the genomic classifiers might help to make the decision whether to treat or not treat in that space.
Probably for the sake of time, we should move to the metastatic setting. We have hearing since last year about doublets versus triplets and who is the best candidate. And we have 1 year of debate, and until now we have not yet fixed who is the best candidate for triplets. Now we know that a doublet with docetaxel is not anymore a standard of care, that we have clear. But we don't know which are the most patients that will benefit from this triplet. And a part of this, if we're doing intensification therapy in the metastatic setting, triplets with doublets with new hormone agents, what is left for castration-resistant prostate cancer? When we have a progression in here, what are we going to do with the patient in the castration-resistant setting? Philip.
Okay, so I think there are a few things to say there. So the first thing is that we don't know. We don't absolutely have the data on who should have triplets and otherwise. I would say that when we only had docetaxel for people with hormone-sensitive prostate cancer, it was clear that not all men with metastatic hormone-sensitive prostate cancer got intensified treatment. And in the UK, it was about a quarter, somewhere between 25 and 30%. And it's those people who I suspect some of those people will be given docetaxel at the moment. It is still more likely that those people will be the people who present with metastatic disease and those people with high volume metastatic disease, and perhaps with bone metastatic disease rather than with lymph node disease or visceral metastasis. And I think those are probably the people that are most likely to get it. We still don't have any good data to say that the triplet is better than just a doublet with a ARTA. And that clearly is still missing. And I don't think we will ever really get that data. So there's always a little bit of that. What I do think is that people will not be fitter when they progress. So in the past, what happened is if I gave you a doublet to begin with, and I thought I'll save docetaxel for later, you won't be fit enough to have the docetaxel. So the important thing is if you're going to have docetaxel, you need to have it early, and then you'll get your best response and your best time without a metastasis, and that will then allow us to use it in the most effective thing. And then afterwards, well, that depends on what you've got. So if you've got BRCA mutation, you might have a PARP inhibitor. If you've had triple therapy, you might have lutetium. If you've got mainly bone disease, you might even have radium as your next thing. You could have cabazitaxel. It's not that there aren't things out there. I just think that we know that the majority of patients will get something for their primary treatment. Only about a third of people actually get second-line treatment anyway. When all the studies, it looks very different, but it's not true in real-world data. And the number of people who get a third-line treatment is actually very small. So we need to give it up front. Don't be scared.
For me, and well, for everyone, it's important, as you said, the first-line treatment. Because we know from real-world data that many of the patients, when they undergo one treatment, probably half of them won't be able to receive a second line because they have a progression and they die, or because they won't be fit for a second line. So it's very, very important to have a tool to help us to select which is the best treatment in the hormone-sensitive metastatic setting.
An important point is also, like many of these trials we currently have supporting the early treatment, they have crossover afterwards and you're unable to catch up with the effect that you generate at the first line treatment. So I think there's a strong evidence that you should treat them early. And if you have a patient high volume, high risk, I think there's a sense of triplet because you want to treat him early as good as possible and then benefit of this treatment on the long term. And we have several other treatments with other mode of action you can offer nowadays, lucky us, and then you go down the line of the second line, third line treatment if the patient is fit enough.
We have talked about a systemic treatment in advanced prostate cancer, let's say. But now we are in a new wave, let's say, regarding metastatic-directed therapy. Metastatic-directed therapy, I think, have sense in the era, of course, of molecular imaging. If you have molecular imaging and you have a low volume disease by molecular imaging, that this classification doesn't exist. I have invented it now. I think it makes sense in that way. What are your feelings regarding metastatic-directed therapy in this setting?
I think there is still something we need to learn a lot. We have some emerging data right now. Lucky as we have prospective data, randomized data now on both settings, hormone sensitive, recurrent setting at the very beginning with the stump and areoli. And now we have it also in the cancer-resistant situation. We then need to have some more solid endpoints that give us a strong information in which sense we need to go. But I think it's interesting. And as you said, I think nowadays, with molecular imaging available, this is a way to go to select the patients and treat the patients. We have from areoli the comparison between the patients treated only on conventional imaging and then having also PSMA information together. And if there's a match between PSMA lesions and conventional imaging, you're quite successful on the long term with the cancer control. And if there's a mismatch between PSMA and conventional imaging, meaning that you treat some lesions on conventional imaging, you leave lesions untreated based on PSMA, then actually the curve drops and you're not effective. So if there's a way to go for this kind of approach, then it is molecular imaging based on PSMA.
Yeah, I think there's one other thing to add, actually, because there was some quite interesting data this morning from the Extend study showing that if you add molecular targeted treatment to androgen deprivation, that actually you get a significant improvement. And I think that historically we have looked at targeted treatment to try and avoid androgen deprivation. That's been part of the rationale, but I'm not entirely convinced that that will come to be the most effective way of giving it, and we probably need to think about how we would combine at least short-term hormone treatment with metastasis-directed therapy as a way forward, rather than trying to delay giving them the hormones forever, because I think they'll get a better response like that. That would be my reading of the early data.
We can conclude in this discussion that in the metastatic hormone-sensitive prostate cancer is not ADT for everyone. Now we have ADT plus something. Something could be chemo, new hormone agents, radiotherapy, metastatic-directed therapy. And probably we, by the time, miss a tool that help us to select which patients fits for the best treatment, because the first treatment is very, very, very important. Now, moving to the last discussion is regarding the adverse effects and how to take care of the bone, because Dr. Walz presented our results regarding this. The data that we have regarding zoledronic and denosumab are from the time that prostate cancer was treated only with ADT. And we do the same as we did 10 years ago. Now we have a lot of new treatments. Can we extrapolate this data now? How should we take care of the bone nowadays with all the new agents that we have in the market?
But we have more data than that, don't we, from piece 3? Because in that, we showed that those patients who had combination treatment with an ARTA plus ADT had a 16% fracture rate if they didn't have bisphosphonates. And so we have talked about intensification of treatment. This is data out of a randomized trial. I went home, found all of my patients who were on intensified treatment and put them all on bisphosphonates when that data came out. This is the way forward. And it's not surprising that the STAMPEDE data shows that there is an increased fracture rate. It's interesting, the HES data is independently collected data, so that it's hospital episode data. So if you get admitted with a fracture, these aren't people who had asymptomatic fractures. They're not people who had something that was only picked up on a scan. These people had to be admitted or had to have it recorded in their GP record, mainly their admissions, that this happened. So these were symptomatic people who had fractures from the STAMPEDE data, and on that basis it probably underestimates how many people would benefit from it. And if you looked at the people who had bisphosphonates in P3, they didn't get fractures if they had it. So there was a really big difference between those groups. And so I think that bone health is something we need to take care of for people who are on very intense androgen deprivation.
I would love to continue the discussion with you, but time is up. Thank you very much for being with us today, and thank you to the audience for watching this video.